of table. When the patient becomes stable, patient jump out of table and some way the on-site some was putting one of my anesthetist and other technician is just hold the patient and lie down on the table. So stand from the ostium of the left vein to the LAD. That was 3 to 32. Was dilated with at 8, that was deployed at 8 ATM. Balloon was pulled back and inflated at 12 ATM. Post dilatation with 3.5 and subsequently 4 millimeter NC balloon. And this is the razor. LCX dissection was 6. There was some loss of contraction of the LV, but patient survived. Until now, patient is doing well. It's reduced ejection fraction around 40 to 45. So when the jet of can I stop here? So this is another case jailed oil when it's really jailed. It was got free, but filled with the stent. That is so this is the left-hand bifurcation on Medina. Pull-out stenting was the strategy was to do the pull-out. So everything was fine. Predilatation, wiring predilatation, then IVUS, everything we did. So this is so what happened? When I tried to pull out the jet wire from the, initially I put the stent on the left ventral LCX. Jet wire in the LAD, when I pulled back, initially there was resistance, it was coming out, but at one point I feel loss of resistance. So I thought it is the wire is fractured, but still there is some connection, so I immediately put a microcatheter fine cross over the wire, but microcatheter goes into the outer rather than going into the behind the stent. So I was sure that wire is totally fractured and separated. So I did the IVUS to see whether the wire, that is the fractured wire, is outside the stent or it is totally within the LA. The video is not, this is the picture like this. This is the fracture wire. So I tried to, I think there might be a small, that maybe the millimeter that is outside the stent because there was nothing in the IVUS. There was nothing outside the stent. So try to do the wire wrapping. This is the third wire I took and I wrap it like this. And tried to pull back, it was coming out easily. But at one point, the fractured wire separated from the wrapping wire. So wrapping wire come out, you see the wrapping wire is coming out here, but the fractured wire is here. So I took a 2 balloon in. I took a 2 balloon over the wire, but it was not going. So I took the balloon without any wire. So that easily goes up to the end of the catheter. I jammed the both wire and pull back all together. And this, up to this moment, you see there is a stent in the left vein, there is a stent in the LCS. But after pulling back, when I engage the catheter, there is nothing in the left vein and LAD, left vein and LCS. So the stent is come out with the gel wire. So subsequently, I do the procedure that was finished within half an hour. And this is the final result. We tried to find out what the stent is, but we did not find it out. No, that was not within. Actually, that was totally disrupted, like in wire like this. So this is the last thing. Knuckle one is a very difficult procedure, especially in retrograde CTO. The retrograde, I don't do the retrograde very occasionally. But this is the very difficult cases. I did it, and that retrograde wire, when I tried to go to the RCA proximally, it was not going. So certainly it was naturally knuckled and go into the lumen. So that is not my technique or not my credit. That is actually spontaneously that happens, and ultimately that was done. So these are some things that I have ever seen, that may be the single times or maybe or 3 times in my life. Thank you.
Thank you for all the beautiful cases. We have also not seen these before. Thank you. The last speaker of the session, Dr. Habibur Rahman.
Great cases. My sister is there. What is the platelet regimen for the first cases?
What was that?
Antiplatelet regimen. Yes, because after 7 years, even then, it can be patterned very nicely.
He was only on aspirin and clopidogrel.
Dual antiplatelet.
Dual, but only clopidogrel, not ticagrelor, not
Aspirin plus clopidogrel. Thank you.
Last speaker of the last session, Dr. Habibur Rahman. I have never seen this before. He is also from Heart Foundation.
Good evening. I'm Dr. Habibur Rahman. I have never seen before because it's a case of scan also. I'm working in one of the high volume centers in Bangladesh. So scan is in acute coronary syndrome as per literature 1 to 4%. So we have to encounter off and on scan. But this case is a bit different. That's why I have never seen. So nothing to declare. So this case was 46-year-old young man suffered from COVID-19 infection and acute angina 1 MI, treated conservatively in another hospital without invasive facilities. He was referred to us for cardiac assessment as had recurrent chest pain. His ECG revealed recent anterior MI. Echo showed gross anterior wall hypokinesia with LV 28%. X-ray chest revealed cardiomegaly with signs of pleurisy. And we did the coronary angiogram. It revealed total occlusion of left anterior descending artery at proximal part, LCS codominant vessel having spontaneous spiral dissection in its proximal and distal parts with good TIMI flow. And also in RCA, which is big vessel, had scan from mid to distal part with good TIMI flow. So this was the angiogram. In left hand side shows the left anterior descending artery is totally obstructed, possibly by dissection, and also SART has proximal scab, distal scab, and on the right hand side, right coronary artery has also scab. So, it's total occlusion of LAD and also scab in the other two major vessels. So, like this, the total occlusion of LAD, scab in LCA and RC. In LAD, it is said that as per classification, the scab is class 4. In other two vessels, class 3. So, what should be the management strategy? Can anyone please suggest me? Yeah. The patient is symptomatic, having chest pain. So, as per guideline, if the patient was stable, I would straight go for conservative therapy. Is symptomatic. So, revascularization is needed. But which vessel? Definitely the left anterior descending artery. So, we engaged EBU 3.5 and one run through floppy wire put in the ramus intermedius to guide us, and another wire through microcatheter trying to find the lumen in LAD. After confirming the entry into LAD by the workhorse wire, we exchanged the two XT wire, kept moving and made some progress because it is also scared. So I was scared. Wire couldn't pass to the distal true lumen, but I could inject through the RCA because there is scab. And change the wire to pilot 50 with changing the curve of the wire tip and enter the distal true lumen at this time luckily. Now exchange the wire and carefully pre-dilated the lesion. One DES 2.75 by 48 put distal because longer stent needed to cover the dissection. After assessing the left main, proximal LAD and the length of the residual lesion, took another DES 3.5 by 38 from left main to LAD overlapping the previous stent. So stent deployed and pull dilatation with NC balloon, check with stent boost for optimization of the result. Further optimization by dilating with higher balloon in the left main and posterior LAD, and good timid flow established, but at the expense of the ramus intermedius. We tried but couldn't get into that and didn't try hard. So, in conclusion, spontaneous coronary artery dissection is uncommon but important cause of acute myocardial infarction, particularly in younger women and patients with underlying fibromuscular dysplasia and other inflammatory disease. And large proportion of patients with SCAD report significant emotional stress immediately before the event, and more likely than the patient with atherosclerosis related acute coronary syndrome to report such stressors. frequency of association of COVID-19 infection and scare, its pathogenesis, treatment protocol needs to be further studied in larger scale, and also how to manage needs to be studied further. So thank you all from National Heart Foundation of Bangladesh.
Thank you very much, Dr. Habib Rahman, for your wonderful demonstration of a rare case. Now we are at the brink of the close. May I now request Professor M.G. Azam to say a few words and
Thank you, Alice. Actually,
also give the crest to the speakers.
now, actually, before going to my conclusion, I just want to